So this is an overview, my steps to organize this presentation. First, I would say, what do we really mean by integration? It's a very complex term. What exactly are we integrating? Almost no one agrees on that. Why are we integrating? What's the pressure for this? How do we actually do it? And I think more importantly, how do we sustain an integrated, collaborative effort? 4, does it really make a difference to anyone? And why does it make a difference? What's the evaluation data have to say? And then how should we evaluate it? I want to talk a little bit at the end of the presentation about the kind of evaluation model that makes sense to understand integration, because some of our traditional methods really do not make any sense, which is one reason we don't know very much what's going on. So this is the presentation. So first, what do we mean by integration? And clearly, integration does not mean the same thing to everyone who's involved in this complex process. Many actually think of it along a continuum. So maybe think about your mental health and addiction services, or your mental health and your primary care services, or your justice system and your children's services. It doesn't matter. When we use this term integration, one reason it's very confusing is because people are often talking about this continuum, and they may have their own project, but it's focused only on, for example, networking and partnerships. Another project might be about full integration, structural management integration, administrative integration. And in other cases, they may be just talking about doing a better job of communicating with each other. So the first thing when we use this term, researchers, we need to define what it is we're really talking about. There is a distinction, and I'll speak a little bit more about the services versus system integration, so just hold that. Many of you will be familiar with functional versus horizontal integration. I won't go into the detail in time, but it's common terminology to understand how organizations work. And then one thing that we do not talk enough about, but there was some very good work done here in Quebec a few years ago that talks about normative integration. And what we mean by that is really integrated thinking, integrated value systems, integrated ways of doing business. And this is particularly important when we talk about the integration of mental health and addictions, or the integration of any socially oriented services with services that are more medically oriented. They don't think the same. People involved have a different kind of way of thinking and different training. And some people think that all of this technical integration will actually not go very well unless you start by understanding and synchronizing the value systems and the perspectives of the people involved. We also, you'd be familiar with this term, I think, continuity of care, which sounds like a good thing. Make the person's experience meaningful and continuous. It doesn't have one treatment episode here and another one here and another one here, and all the information is separate. His treatment episodes are separate, and no one knows about that or even cares about that, and this is a problem. But even this term continuity of care has different nuances. We can talk about the continuity of the information. We do focus groups a lot in our field, and one thing that drives people crazy is going to one place, telling their story, going to another place, telling their story, et cetera, et cetera, et cetera, because there's no continuity of the information. Then we have kind of a management continuity where we may have different professionals involved that are actually talking to each other and developing a care plan to manage, to support the person together. And then this one is very interesting, that we actually have a continuous relationship with the person. This is very difficult because we have turnover of our staff, but also that we have handoff, like, for example, from youth services to adult services. There's a complete break in the relationships, as many of you know. So even this term continuity of care can be quite complicated. Many people think collaboration is a kinder word. And you might think about this as really a continuum of different levels of collaboration. I was involved in a report recently with the Canadian Centre on Substance Abuse with many people to try and identify best practice for integrated services. It was very complicated, and the group finally agreed not to talk about integration because it was almost too emotional. It's better to talk about collaboration, and there are many forms of collaboration, including integrated services. Okay. This is just to help make it real for you, try to bring it down a little less theoretical, this distinction between service level and system level. For me, this term here means what are we doing with the people who come for help? Coordinating our services at the person level. We can have integrated clinical teams, mental health and addictions, primary care providers all working together, or we could have case consultation where I can phone somebody or bring in someone as a consultant. We can have co-location, people working in the same place. We can have addiction liaison nurses, which are very common here in Quebec. Why I put this example, it's actually somebody located where the people are who need help, and linkage managers or case managers. So there are many forms of this, but this is at a different level. This is how we might organize and coordinate our system. It's in support of this, but it's at a different level. Coordinated access, this is becoming very popular in Ontario. We might have 10 services in a particular region, but now all access will be centralized through one place. You don't exactly have this challenge in Quebec because you have larger, more multifunctional centers. So it's not exactly what's the problem here. Shared electronic records, interagency agreements, etc., merge planning. So these are structural, administrative, integrative activities that are a little bit far removed from the person. I want to tell you a story about co-location. I have the pleasure of being asked to help or to study integration in different parts of Canada and also internationally. So there's two stories I want to tell you. One is about co-location, and this was in Saskatchewan, Saskatoon, and they had, quote unquote, integrated the mental health and addiction services, and they thought it was a good idea to get everyone to work in the same building. They shared the same parking lot, but they had two separate entrances, and all the mental health staff went in one door, and the addiction staff went in the other door, so it didn't work. The other story I want to share was in Prince Edward Island. So it's a small, beautiful place, and I'm making a presentation, maybe 20 people in the room, and I thought, this is the leaders, this is the senior clinical staff, and I thought, and they had mental health and addictions. And I said to them, I paused and I said, this should be easy here. You probably know all the same clients. Somebody puts their hand up and said, Dr. Rush, we're related to all the clients. And they were still not integrated. So, and then this question, when the theme of your colloquium, integration of addiction services, it doesn't actually say with what, right? But that's likely intentional because it's not an easy thing to figure out. Are we integrating alcohol and other drug services? And some people might think, well, we've already done that. And there has been a big change historically. We had our services initially were very focused on alcohol back in 1950s, 60s. And there was a big change with the advent of street drugs. And now in most of our addiction programs, it's a melange. You have people with many different alcohol and drug problems all mixed up together. But we do have one anomaly. We have services for dependence on opiates that are actually quite independent of our alcohol and other drug services. So we still have some challenges here. We have prescription of methadone or buprenorphine, quite separate. And there's some concerns about that, and some people think, well, that's okay. But we have a bit of a problem right now to figure out exactly what's appropriate distance or not. Secondly, are we integrating services for particular populations? And this is a really big challenge across the country, because we have services for youth, and typically at the age 16, they are not eligible anymore. And then they must really start again, and very little transition support. There's some good models in the literature how to help transition youth, but maybe when we're talking about integration, it's really about populations. Then we could actually think, are we trying to integrate different substance use services? So what's the connection between withdrawal management, detoxification, and treatment? Or what's the connection between treatment and aftercare and continuing care? We would like to place the person into a seamless network of services, because there's a tendency to lose people, not because of their challenges, but more because of our challenges organizing a system that provides continuity of care. So sometimes we're talking really about our own specialized services. But more often, and more recently, we are talking about the integration of our addiction specialists with people who are not so specialized, with generic mental health or primary care or justice. So I think most of my presentation will focus here, and there are some particular challenging issues in Quebec at the time, and also in most of the other provinces, but particularly here at the moment. But if you're talking about integration, let's be clear exactly what we're integrating. So this is a bit of a, I'll say old problem, but it's still a challenge. We, in our country and many other countries around the world, have created a very specialized network of alcohol and drug services and a very specialized network of mental health services. It's important for you to realize it's not like this everywhere. In Latin America, for example, these things kind of go together pretty seamlessly. And they tend to be organized around hospital care. So people don't have a trouble getting both mental health and addiction support. But after they leave hospital, there's nothing. In Belo Horizonte, for example, in Brazil, a population of 8 million, there is one addiction program in Brazil. So other places have a challenge with, they don't have very much. We have a challenge, we have a lot, but it's not really working together. So we need to keep in mind and maybe respect what we do have here and focus on doing good with what we have. We do have a lot of services. So exactly why are we integrating? This is really the big one that's often top of mind. Comorbidity, problems go together. In fact, for many people, they don't care if it's a mental health or an addiction service or a social service or a doctor. They just want help. They just want help. And our systems are organized to make that a little bit challenging. So we know a lot about this now, in particular mental health and addictions, but it's also true. What we now use a term multi-morbidity. So because mental health, addictions in a severe level also go with challenges around housing, challenges in physical health, in corrections, so it's like a piling on of the problems. The more you have, the more you accumulate. It also impacts on people's access. It is exacerbated by a lack of screening. People are often afraid to ask about certain questions because they don't know what to do. It's like a Pandora's box. Let's not open the box. Then we have clearly an impact on client satisfaction, the perception of care. People with co-occurring problems do not generally have a good experience compared to people who do not. And then there's an impact on their actual outcomes. I thought I would put a classic case, which makes this, again, a little more real for those of you who do clinical work. How many in the room actually do clinical work? Yeah. So these cases will not be a surprise to you. And I'm assuming people can see on the video screens at the back, because I know it'll be small print. So here's a gentleman, 35 years old. He's referred for a psychiatric consultation. He has been in treatment 13 times, and he's only 35. This is actually not unusual. So his first encounter was age 14. It's really a story of kind of social anxiety and low self-esteem. He began to drink to fit in. For the past 15 years, he's been managing the ups and downs. There's your first clue. It's a classic case of unrecognized social phobia and bipolar, combined with alcohol abuse. This is a true case. In 13 episodes, he had never been asked any questions about his mental health. 13 times. So what's his prognosis? It's not very good, partly because of how long this went on. So it's just one example. People often think mental health and addictions always go together. I often encounter this perspective. It's just not true. This is our most recent, well, actually we have new data from the most recent CCHS survey, but from 2002 survey, it's about 15 to 20% in the general population. And this actually coincides with the most recent US data as well. In other words, it's not 50%, 60%, or 100%. But this is where it gets confusing. This is the situation generally in the general population, and I must say, not all the disorders like personality disorder and schizophrenia, but in general, this picture emerges. But this is where it gets confusing, because in our substance use services, in our addiction programs, the percentage is extremely high. In some programs, it would be 100%. The connection to trauma, et cetera, et cetera. But then, we take a look in our mental health services. It's back to 15%. This is our Canadian data, or Ontario data, provincial data. So why is that? My thinking is that in substance abuse, we have big hearts. We will take anyone. And in the mental health system, with the way the system transformed from institutional services to the community, a new set of rules emerged. Severe and persistent mental illness, or suicide risk. And yes, there is some prevalence there, but we don't have community mental health services anymore where people can go with less severe problems. So they end up going to the addiction program. So this is a matter of selection. And it's also true that if we compare to the general population, if you have these problems, you're more likely to go to help. And the more problems you have, the more likely to go to help. So there's a selection process here. But back to our mental health services, in our own data, if you look at young males in inpatient settings, it's pretty high again. And if you look at the distinction between inpatient, outpatient, and community, so there's a selection process. So if somebody says to you, what's the level of co-occurrence in mental health and addictions, you first say where, and who are you talking about? So this is the lesson. This is a little bit of our qualitative data. I won't go into the detail, but these are some quotes that came from our different interviews. So we have disconnected policies and planning. So we say, sorry, we won't take you here if you're on that particular medication. This still happens. It's less, but it still happens. Programs that are very recovery-based sometimes resist or don't want people there on different medication. We have disconnected information systems. We have these parallel systems say, well, go take care of your addictions, and then you can come back. And we have what we call double trouble, the stigma and discrimination. People just don't want to go for help. Then I think we have this picture. For the integration of mental health and addiction, the train has left the station. There's no pulling back on this train. I think it's on the way. The question is, how is it going, and how are we evaluating our success? So there are also other challenges. It is about comorbidity, but maybe it's also just about saving money, being more efficient. Maybe, this is interesting, it's the flip side, maybe it's about mental health and addictions working together, so together they can get more resources, because they're competing with cancer, they're competing with heart, et cetera, et cetera. This is actually a good strategy, but there carries some risks. There's also distinction between disciplines or positioning of power and authority. Like, who's really in charge of addictions? Is it about mental health and a medicalization of addictions, or is it about a biopsychosocial model that respects and encourages all disciplines to be involved, et cetera, et cetera? The interesting one is about wages. People in mental health make more money than people in addictions pretty much everywhere in this country. So there's a bit of a benefit sometimes to equalize. So I'll keep going. But that's about mental health and addictions. What about the larger picture, where we have comorbidity, co-occurring problems, et cetera, et cetera? And I want you to keep this in perspective. If you want to find people with co-occurring challenges, look in our prisons today. They are really the new mental health system in North America. So here's a different kind of a diagram that places our mental health and addiction services, our comorbidity, in the context of the healthcare system and a whole range of resources that are needed. So what's the goal of any prevention treatment system? It's about quality, and it's also about coverage. In other words, we want to organize a system that can cover the whole population in need. But what do we mean by need? Working with Joelle and others on a national project, we have defined need in terms of levels of severity. And at the top of this pyramid is our co-occurring disorder population, but it's small. And we then want to organize, we actually have data for the Canadian population on the level of need and organizing in terms of the level of severity of substance use. And then we need to map this onto our treatment services, and it is here that we need highly integrated care, not necessarily for the whole treatment system. Back here. So then I thought I would show where we are now in terms of our technology and our knowledge base for actually integrating services. In other words, we still have a ways to go. It's not quite the rapid high-tech train that we have already seen. So how do we achieve and sustain integration? This is a question, how are we going to do it? Mostly we just hope some miracle occurs, because we really have no idea how to do this. I'll just make a distinction between what I call the big world top-down and the little world bottom-up. And I think the process underway in Quebec right now, I understand, is pretty much a classic example of top-down. This is actually the most common. But the other way is just clinicians and people working together on behalf of their clients and creating community networks of support and social systems that support people. So the question is, how much of this small world work of yourselves requires administrative organization? And that's a question for research. This is something I learned recently, a presentation in Finland. There was a person presenting, and he talked about archaeological research in the study of mental health and addictions integration. And what he was saying is that most integration processes are one of increments. You very rarely start everything over again. So you tend to go in like small steps, okay? And so to understand this from a research point of view, you need to dig down deep, because everything is buried in layers. Very rarely does someone start with a whole new idea. You are building upon your history. Then I want to show you, since come from a farm background, people always use this language where we don't want silos. Our health services are too siloed. I just want to remind you of the purpose of a silo. The purpose of a silo is actually protection. It's not necessarily a bad thing. The question, if you have a silo, is how efficient you are in moving things in and out. So I'll just leave that with you, that people say, well, it's important for the addiction services to be part of everything. Yes, we do need to be involved, but there is a risk that we lose some of our expertise. So then we have the issue of evidence. And we have our poor scientist here trying to integrate services. He has a lot of theory, and he has absolutely no proof. And one of the reasons is that there are so many variations in levels of integration, types of integration, that you cannot synthesize this literature. We have tried to synthesize this literature. It's too complex. So there is no real synthesis of outcome. And the most recent economic analysis was also not able to really come to any big conclusion because there's just too much variability in the field. So I want to finish with this last point on some challenges in our evaluation. Our traditional research methods have a difficult time understanding the importance of context. So what do I mean by that? If we are running an experiment, a random controlled trial, randomized trial, we are trying to organize things to remove context so that the important parts are left to study the intervention. But there is no integration activity that exists outside of its context. It cannot be understood outside of the context. We cannot study Quebec integration in Alberta. Okay, or we cannot apply necessarily what we've learned in the United States to Quebec. Everything depends on context. Then we have this challenge that there's a lot of other things influencing outcome, not just integration. So what are the therapeutic factors related to outcome? Think on that. First, roughly 40% of our success depends on things the client brings to us. Severity, their circumstance, they have a job, they're in a good relationship, they're motivated, etc. 15%, I'm sorry, depends on our technique. You. 15% depends on you. 15% depends on expectancy. In other words, if you believe it, and you convince them that you believe it, they will believe you. Something like that. And then the therapeutic relationship. So in other words, our integration activities have a relatively small chance of making a difference. Or our research projects have a relatively small chance of finding a difference. And many of you know Louise Nadeau, the icon in our field in Canada and certainly here in Quebec. She's the one who reminded me over and over again that even if we integrate all the services in the world, we need to develop a therapeutic relationship with the person, and that's what really makes a difference. Systems are never static. They are always changing. So if I want to study this one integration activity, say in Quebec, we wanted to study what's going on in Quebec, we must understand all the context in Quebec to understand what's going on. Systems are never what they appear to me. I'm reminded of our archaeological story, because typically when we study an integrated system, we kind of look here, what's obvious. But everything that's important is down here. Because there is this incrementalism, this layering of experience and change, and all the good stuff is here, including all the truth and the lies. Health outcomes are often very far from the integration effort. And just a reminder, if we are integrating services, that we are a long distance from the health outcomes. So we can study continuity of care, we can study access, we can study how information moves, but it's very challenging, I think impossible, to connect our integration activities to a real change in outcome. Implementation of any system never goes smoothly. We're going to study an integration activity, and it's already starting to change. It's not what it is today. It's always in flux. And I love this slide. I'll leave this one with you. If we are planning an integration activity, this is what the customer wanted. This is our focus group with the consumers. And this is how the project leader thought he would go about it. And then he gave it to an analyst, and they went a little crazy. And then we gave it to the computer programmer, and it became a real mess. Then they had the business consultant, and they decided they need to make it look pretty sexy. This is CAMH. This is the this is the CAMH. We have a big, beautiful sofa. And then this is how the project was documented, which is there's nothing, also CAMH. And then this is the first installation. And this is how they billed the customer. This is the government invoice. And then this is how it was supported at the end. It was not very much. And then they actually went back to the customer and said, this is what all that they really wanted. They just wanted help. Okay, so I'll leave that with you. Is there any room for optimism? I'll just leave this model with you and ask you if you are still in school or working on the evaluation of integration to take a look at this realist evaluation model, because it's designed to understand context. It's not necessarily qualitative, it's a mixed methods approach, but the way they go about it in developing a theory of change behind an integration activity, then I think we have some hope for success, and I'll leave that with you. Thank you very much. Yeah, I think, well, one thing I wanted to relay was the combined power of being together. Mental health and addictions is a positive thing. In most of the provinces, we have a mental health and addiction strategy. They are combined. The resources are now being combined. It's a good thing, but the implications are not being monitored. One example, in most of the provinces that have integrated mental health and addictions, they replace the managers. This is happening here. They will replace the managers. The new ones will probably come from mental health. Yeah. This is happening across the country. I'm going to Vancouver tomorrow to make a presentation to educate the leaders of one of the health authorities about addictions. And they run the addiction services. It's a classic example. So there are benefits, but the way it's being implemented is not being monitored. And there is more political benefit for addictions, but in some ways, it's creating more challenges for addictions.